Good afternoon, Dr. Janower.
Good afternoon to you.
To start off, could you tell me where you went to medical school?
I was graduated from Wayne State University College of Medicine in 1958. I received a Distinguished Alumnus Award in the year 2002.
When did you start practicing?
I trained from Wayne. I went to Philadelphia General, where I had a rotating internship, and then I came to the Massachusetts General Hospital, where I took a residency in radiology. After I'd been a resident for 1 year, I was drafted and went into the Public Health Service, where I was stationed in Washington, D.C. I was the second radiologist in the brand new Bureau of Radiological Health, which was the second agency to get involved in radiology following the Atomic Bomb Casualty Commission. I spent 2 years in Washington and then came back to complete my training at the Mass General, where I completed in 1964. I then stayed on the staff for 7 years or so, where I did a number of the CPCs in the New England Journal, and I was running about 3/4 of the department when Dr. Harold Jagers invited me out as a consultant to St. Vincent Hospital in Worcester. This was in 1970. I must admit that I had heard of Worcester, but I had never been here before. When, when I came out, I found a 600-bed community hospital whose radiology department required major upgrading and changes. I submitted my consultation report, my report as a consultant, and as a board of trustees began to say yes, 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 and yes, I began to realize what a precious gem St. Vincent was, and I thought that I really should perhaps come out, since I was interested in staying in the Boston area. I had never looked for a position, but the opportunity here at St. Vincent was really quite unique. Dr. Harold Jagers, from the Peutz-Jeghers syndrome, had come out to St. Vincent some years before with the concept that the community hospital was the place for teaching and training of medical students and residents, a thought which was relatively foreign in those days, where most community hospitals, almost all, were only involved in clinical care, and the thought of doing research or of training was very foreign. When Dr. Jagers came here, I think he experienced a lot of resistance and hesitation on the part of many of the older staff who really did not understand the need for teaching and research and the fact that it could occur in a community hospital. As I looked around at the people that Dr. Jagers had recruited, it was really quite astounding. Among others was Dr. Brownell Wheeler, who was the first professor of surgery at UMass, Dr. Henshaw, who was the first professor of pediatrics, and some very well-known other individuals like Dr. Gilbert Friedel in pathology, Bud Rose in rheumatology, Earl Weiss in chest, and these were people who could be on the faculty at any medical school. They were very prolific at the time and were very involved in a great deal of teaching that went on. So I came out, actually I started on April Fool's Day in 1971, and brought along a staff of 6. We brought the first full-time angiographer and the first full-time neuroradiologist to Worcester. At the time, there were either 6 or 7 hospitals. UMass did not have a facility, only talking about starting it up. And Memorial was a very strong hospital. There was also Holden, and there was, what else was there? And there were a few other smaller hospitals. And So there was, it was Worcester City, which had been a very major power, but was on, I think was going downhill by then. And there was St. Vincent. So we came out and began by, the facility here, in terms of radiology, was really very, very antiquated. So that we decided to build a new department, and we decided to add a wing onto the old radiology department at the old St. Vincent Hospital on Vernon Hill, and we decided to add a wing from the second floor, which is where radiology was. And what we thought was that we'd put the wing up of about 26,000 square feet, and we'd put it up on stilts, because there really wasn't money to go ahead and build the first floor. But then it turned out that it was cheaper to build walls than it was to use stilts, so that the emergency room found a new home underneath the radiology department. We were held up in our construction because those were the days when health planning first came into being under the Nixon administration, and the health costs were skyrocketing. And President Nixon, in addition to other things, put a wage price freeze, but in addition started certain health planning agencies. And we in Massachusetts had one of the first certificate of need laws, a determination of need, before the rest of the country. Massachusetts has always been the hotbed of new regulations as well as of taxes, as we all know. So by the time we finally got approval of the various healthcare agencies, the new department probably wasn't finished till about 1974 or so. When it was a very unique department because it was one of the few in the country using the European core design, where there were rooms basically around the periphery with adjacent patient waiting and interpretation rooms located close by the rooms where the examinations were done. In addition to that, of course, we brought in multiple view boxes, which are now so common, which I don't think anybody had in Worcester at all. And we really built a very nice department. At about that time, in 1972, I believe, this new invention called the CAT scanner was invented, maybe in 1972, and there's some debate as to whether the Mass General had the first one or whether the Mayo Clinic had the first one. I think Mayo may have had the first one. And we decided that we really should have one at St. V's. Well, this was really quite dramatic because the cost of a CAT scanner in those days was close to $1 million. Prior to that, equipment was thought to be expensive if it cost $50,000. And for example, a new angiography room, which we put in, of course, the most modern that was possible, cost $200,000. And all of a sudden, you've got this machine that may cost $1 million. And of course, the health planners were going nuts because they didn't know what to do about them and how to handle it. And of course, I think that CAT scanning is what killed health planning in general, thank God. The bureaucracy was very overwhelming for all of us. And the state, in its lack of wisdom, decided that since they didn't know what to do with it, they'd put a moratorium on it, and they wouldn't allow any outside of 128. We got the first one finally. We had to go to our local planning agency, whose name was, I forget what exactly its name was, but we went before them, and coincidentally, there was just at that time, as you know, the CAT scanner started with just the head CAT scanners, were really very primitive. And we did indeed have, rather than have one of those, they had just gone ahead and invented one that could also do the body, Well, the regional health planners were very concerned because they thought that the use of the CAT scan outside of the head had no value whatsoever, and it was just a waste of money to do that. Well, of course, we know how wrong they were today. This is one of the greatest revelations that ever came into medical care, one of the greatest inventions of all time. So we finally did get that CAT scan, and we had the first one that was outside of 128. We also did some other very interesting things. I think we're among the very first, and maybe the first, to get involved in lung scanning, which is now so common, of course. We were the first to use ultrasound in obstetrics, which of course is absolutely routine now. We were among the very first to begin doing that. Mammography had been done here in Worcester, but we got very involved in mammography even in those days. And the other thing I did was we were determined that radiation oncology should be a separate department, should be a branch off of diagnosis. Until those days, in most community hospitals, radiation therapy was just done by diagnostic radiologists. I think in Worcester at that time there was one cobalt unit, but there were no linear accelerators. So I was determined that we would have a separate department of radiation therapy with a full-time, fully trained radiation oncologist, and we got the first linear accelerator. That I think that was out in Worcester. I know that was the first one we got. That was in Worcester. So we did that. So that we had a lot of things going here. We also got a full-time physicist because we thought that radiation protection and radiation physics was so important. We also, of course, started the first radiology residency program. There had been no residency programs in Worcester at all. There was no medical. Memorial, which was a big hospital, which had a fine department of radiology, by the way, had never gotten into the training. So we started the first radiology residency program in Worcester. And then, of course, when the school finally got rolling, we did almost all of the radiology rotation for the medical students. And as a matter of fact, I think the first class may have graduated in '76, I think, I'm not sure the exact date, but of the 16 students who started, 4 went into radiology, which made us very happy, of course. And they were all the best students of the class, or among the best students of the class, we thought. So that was the status in the early 70s to the mid-70s when we came out. So where shall I go? What would you like me to do from there?
Actually, I'll just ask you questions.
Yeah, by all means, certainly.
You don't have to talk the whole
Certainly.
So what made you choose your specialty?
Well, I think that I liked to be a general practitioner. I was not interested in simply looking at one part of the body, such as kidneys or lungs or nerves. I wanted to do everything. And as I looked around, there were not a lot of specialties that did then or do now everything. There was certainly family practice and internal medicine, maybe general surgery, but I thought that radiology was really the one that looked at all fields of medicine, that one could be a consultant. I liked working with patients, but I also liked working with other doctors. And I thought that being a consultant and working with other doctors on different patient, a vast variety of patient illnesses would be just terrific. And that's why I picked radiology.
So could you describe a typical day when you first started practicing in terms of your hours, your rounds?
Well, those have never really changed. The hours we usually would get here around 7:30, and we probably would leave around 5:30 or so. Would spend the day very busily taking care of patients. We had about 150 to 200 patients a day that came through the department. Much of my time was spent delivering clinical services, interpreting radiographic exams, doing procedures, but also was spent administering a big department with 100 employees and patients, some deathly ill, some not ill, being sure that they did not have to wait too long for their exams, that the examinations that were performed were of the highest quality, that they were interpreted promptly, that the reports were communicated to the referring physician so that they could take care of their sick patients. We also had, of course, our residents, so we spent time teaching them. We always had 2 conferences a day. We also had medical students with us where we tried to help the students and teach them some medicine. And, you know, our goal here has always been be a good doctor first, then you'll learn how to interpret the images. So very heavy on quality medicine and surgery. It's very challenging.
So who were your patients generally?
They were just everybody. Whoever was sick and came in the hospital. We had 600 beds in those days, plus a lot of outpatients from the who were referred in, who needed x-ray work, radiology work.
And most of them were from around the Worcester area?
Yeah, most of them were from the Worcester area, right.
So what do you think it was like for your family to have a physician in the household?
Oh, I don't think that it had any real impact. I think that whatever I did, that we were able to, I think it was just fine. I don't think it would have mattered what I did. Okay, I don't think it had any great impact. As a radiologist, we did have a little bit more control over our lives. We did not have a very busy emergency call that many physicians had, but we still had emergency call, but probably not quite as much. And being a part of a big group practice, we were able to divide up the emergency call and the work, because now we're up to 6 or 7 or 8 or 9 of us, as opposed to being a singleton having to answer everything. So it worked out very well.
What made you decide to become a doctor?
I like to take care of people. I like to do good. I think that's a very common sentiment among many people. I found it fascinating. And, you know, so fascinating I really could not restrict my interest to just one piece of the body, but, you know, at everything. I think medical mysteries. The radiologist is a detective. I like being a detective. I like solving mysteries. In comes a deathly sick patient. What's wrong with them? If the clinician doesn't know, to help them figure out what's wrong, what's the final diagnosis, was wonderful. The ability to save lives was phenomenal. I think I always took great pleasure. I used to come home at night, say, I think I saved 3 or 4 lives today, you know, just in terms of providing information that the doctors could act on. That was so very, very vital.
Do you have one favorite memory from your...
No, I don't think so. I don't have one favorite memory, and I don't think I have one favorite dismemory either. I think things happen on a daily basis, and no great, you know, no, it's certainly nice. You know, you talk about memories. I think building the new department, I think knowing that we're giving the finest radiological consultation available, giving optimum service was always very gratifying to my staff and myself. I think the greatest memory was I was able to recruit a wonderful group of radiologists, and we worked very closely together, and when you figure it out, we probably spent more time with the radiologists than we did with our family. You talk about families. Well, you know, if you're working from 7:30 to 5:30, and then you go home at 6:30 to, you know, 10 o'clock, you're spending more hours during the week with your colleagues than you are. And, you know, the nice thing about St. V's was that the patients who came in were so sick that it was really a challenge to figure out what is wrong with them, what can we do to help them. And that was always very exciting.
So what were the most typical illnesses or injuries that you dealt
Oh,
with?
no, we saw everything. Whatever came in, we saw more interesting cases. Remember, if you pick out any specialty, for example, you know, the surgeon would see his patients. Well, we would see all of the surgeons. They all came through us. the pulmonologist would see his lung cases. Well, we not only saw his cases, we saw every other pulmonologist, and every clinician's lung cases would come through. Same in the GI tract. The gastroenterologist or the general practitioner might see a case of this, a case of that, but we saw all the cases, and it was really phenomenal. It was really phenomenal.
What was one of the most important breakthroughs in disease treatment during the course of
Yeah, not so much treatment, but in terms of diagnosis. You see, we've been very fortunate in radiology because most of the major advances in diagnosis have come through us. And if you start, when I finished my training, what we did primarily plain film work and fluoroscopy is what we did. Angiography had begun already, but there was hardly any, and basically none. Well, I shouldn't say none, because Memorial did a little bit. There was hardly any angiography in interventional procedures. So if you look at what's happened to radiology, we now have radiologists who put tubes and catheters and do procedures on every type of illness that's conceivable. So angiography really took off incredibly. Ultrasound was just starting. Some people knew about it. As I said, we were the first ones to use ultrasound in pregnancy in the Worcester County area. Unbelievable. Mammography was just barely starting. Many people didn't even know what they were, what an X-ray of the breast was for. So we were very involved in that. You see what happened to that. And then, of course, CAT scanning came. You know, CAT scanning, when it started, as I've already said, because the equipment was so expensive, and nobody knew what was happening with it. There was, for example, very early on, I think in 1975 or 76, where CAT had been here for a while, there was an article published by some of my colleagues from Boston, and it was entitled Cat Fever. And cat fever meant that they were appalled that it might be that any patient who came into the emergency room with severe head trauma, instead or in addition to having plain films of the skull, they might all get CAT scans. And just think of what that would do to the cost of health care.
Yeah.
Well, of course, you have to do CAT. That's a standard of care. You can't possibly do that. So CAT scanning came. I've mentioned it. And then, of course, the latest thing that's here, of course, is magnetic resonance imaging, is MRI. And so MRI, you see, when MRI came in the late 70s or early 80s, because of this regional health planning conundrum that existed, they would not allow St. Vincent or Memorial or UMass, which is now up, to have their own MRI machine because they didn't understand what MRI would do, and they were too concerned about the cost. Well, these hospitals have suffered that way until the present date, when Medical Cities, when we opened a few years ago, finally got their own MRI, and UMass, I think, has a certificate of need and may have one of their own, and I hope Memorial gets one. So we formed the regional center, the Central Massachusetts Magnetic Imaging Center, which was based next door to UMass, and which was a part of St. Vincent, Memorial, and UMass. It was staff. So we brought MRI to this community. Having brought it to this community, though, if you had a terribly ill inpatient that needed an MRI, you had to transport them by ambulance over to the regional center as opposed to having it within the walls, and there's certain danger in that. Plus, it was costly. At one time, it cost $500 just to get the ambulance to take the patient over. So between angiography, mammography, and I left out nuclear medicine, which is just going wild. When I came, nuclear medicine was a separate division, was sort of a lost orphan in the hospital. We brought that into radiology, so that the cross-fertilization is just another form of imaging. Now we have SPECT imaging, and now we have PET is here, and PET, proton With the PET, it's going to be revolutionary, and now we have molecular imaging is coming down the pathway. So, and now we have light imaging. I don't know what we're going to do with light imaging yet, but it's coming. So all of these developments have occurred in radiology, and it's the most amazing thing you can imagine. It's very, very exciting. I'm very lucky to have been a participant in this. And you see, when you think about it, you see the CAT allowed us for the first time to really do cross-sectional imaging of the body, of the lungs, of the head, of the abdomen, of the pelvis, which was terrific. The one area that we still could not do as much as we wanted was a musculoskeletal system. Well, in came MRI. Now, MRI lets you look inside the joints, it lets you look inside the muscles, it lets you look everywhere. So it's extremely exciting. And it lets you look into the head in many areas, even better than the CAT scanning. So these are the developments. We've been very, very lucky.
So did you always have access to the new technology?
No, we didn't have access. You had to battle with the regional health planners. But more importantly, and very seriously, this new equipment costs lots of money. And one is very dependent on the hospital finances to be able to purchase this equipment. And it was difficult. You know, in this state, we are so over-regulated that the hospitals have always been in great financial difficulty. Nothing has changed. And it was always difficult to raise the capital or to lease the equipment that we needed. But St. V's was very good. St. V's was very good. And we were the first, or among the first to have most everything. And you had to have it. You want to take care of patients, you want to deliver quality care, you have to have the equipment. You can't do it, or you can't use a CAT scanner in diagnosis if you don't have a CAT scanner. You know, and that's basically what it is. So we've been very fortunate.
Name one piece of technology that doctors often take for granted today that you never had when you...
Oh, no, I think it's all the things that I mentioned. I think, not that they take it for granted, but that they use frequently that they never knew existed and never used, and such as ultrasound, CAT, and MR, and there's 3 of them, and nukes. Nuclear medicine would be 4.
Could you just briefly describe attitudes towards smoking and cancer?
Yeah, well, we've always been extraordinarily concerned about cancer of the lung, and for years we fought with people to stop smoking, long before our present, long before the present programs that exist now. And after all, we were the first ones to make the diagnosis. And here we are, we're sitting here, and every day, twice a week, 3 times a week, it would come a young patient, young meaning, you know, less than 60, with a cancer of the lung. And as you know, the survivors in cancer of the lung is maybe 15% at 5 years, so that it was heartbreaking. And then what we saw, of course, is we saw it in the women. In come the women. It used to be the old men. Now in come because all the feminists had been smoking so much. So that was very heartbreaking, and we worked very hard anti-smoking. In fact, one of the members of our staff was the first one who pioneered no smoking in the hospital. And I think St. Vincent may have been the first hospital in the area that banned smoking. Everybody used to smoke, including the doctors. Wow. So that was, yeah, big time, very big time stuff, thank heavens, yeah.
So in the 60s and 70s, how did patients without money get health care?
Oh, I think the same way they do now. St. Vincent has never denied anybody from having health care, and anybody who comes in has always gotten it. And I hear a lot, you know, still, I mean, that's always been a problem. No one is denied health care. You're not welcome to the emergency room. You're not going to be sent away. You're not going to be sent away and say, if you can't pay for it, we're not going to take care of you. Absolute nonsense. Anybody can come in. Now, if people don't come in for a variety of reasons, well, we have to educate them that they should come in if they're ill, you know.
How about in prevention, you know, people who need care for something that's not an immediate...
Yeah, but there were always preventive programs. St. Vincent always had them. I can't go into all the details of all the things we had, but you know, St. Vincent, being a Catholic hospital,
Right.
was always concerned with sexual promiscuity, was always in favor of abstinence or control over one on, was always very much, you know, against abortion or against teenage pregnancy, and did everything we could to do that. I really was not terribly involved in that aspect, so I can't give you more details about that.
Over the years, how do you think Worcester compares to other places in terms of providing care for the underserved?
Oh, I think terrific, because what I said, I don't know of anybody who's turned away because they can't afford care. I don't know of anybody. They don't come in, that's another story, but I don't know of anyone.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Oh, it's the same as always. The question is whether the government can do a good job. And there is a large group of us who feel that the government doesn't do a good job with most anything it does, and be it from the income tax service to the post office to, I'm very concerned about the Veterans Administration hospitals, which at one time were terrible. Look at the Indian Service, I think it's horrible. Look at many of the city and county hospitals who have gone out of business and deliver terrible care. So that is a great concern. That was a great concern.
What were your feelings on Medicare and Medicaid when they came into
Well, I was very concerned about it. The Medicare came in 1965, before I was here. And, you know, that's a whole subject for about a three-day interview. Okay, so why don't we just let that one go at this time? Okay, I think that patients who need care should receive care, whether they can afford it or not. I think Medicare was one way to take care of the elderly. Quite honestly, I think there are a lot of elderly who could pay for themselves, and it's a burden on the taxpayers to have them under Medicare. More government regulation came in, very, very different. But that's a subject for a separate interview.
So would you agree that government has just gotten much more involved in healthcare since when you started practicing?
Oh, absolutely, and particularly in this state. Massachusetts is the worst. The People's Republic of Massachusetts, with all due respect to our politicians.
So what do you want to see happen ultimately with government in medicine?
I don't know. That, again, is a subject for a
Right.
three-day interview. It is a subject.
When-
Well, I mean, for example, as you know, now they're talking about prescription drug benefits. And, you know, there's no question that drugs are very expensive and that people have got to get their medicine. Whether prescription, personally, I feel that a prescription drug benefit under Medicare will bankrupt Medicare. Okay, well, because it's going to be so very costly. Then you get into all the regulation and so forth. See, before Medicare came, as you know, as you may know, many of us, many of the doctors did charity work. You came in the hospital, you covered it for nothing because it was your obligation as a physician.
Yeah.
Well, now that all went away with Medicare. All of a sudden, since the doctors could charge, they did charge. And I don't say that in a negative way. If somebody's going to pay you for what you used to do for free, you might as well get the money and do it, and which they did, so.
When did HMOs first impact your practice?
Yeah, see, we were here, I'm glad you brought that up, you see, because we were very lucky here at St. V's, and I want to say Worcester, although I don't think everybody will agree with me. We had the Fallon Clinic, and the Fallon Clinic was affiliated here with us at St. V's primarily. And the Fallon came in very, very early to the HMO and to the managed care area, and they really did a very good job. Now you realize that the reason the HMOs and the managed care came was that the costs were just skyrocketing, going up 10 to 20% a year of health care, and we're back to that now, I'm afraid. So the Fallon came in, and they were one of the pioneers in developing systems to deliver managed care, preventive care, where, as you know, patients would sign up for a set fee, and then all of their medical care needs would be helped. So I particularly was very fortunate being here because Fallon was so far ahead of the rest of the country, being one of the pioneers, that I learned a lot about managed care. I was never a part of the Fallon Clinic, who had their own radiology department that took care of their outpatients, but we always took care of their inpatients here at St. V's, and we always had wonderful work, and still do, as best I know, have wonderful working relations with them. So, being in Massachusetts, when I would go around the country, and I was involved a little bit politically, that I would talk about certificate of need or determination of need, nobody knew what I was talking about. When I talked about managed care, nobody knew what I was talking about. When I talked about HMOs, nobody knew what I was talking about, because we were among the first to begin. So managed care has its benefits, and it has, and it has some things that are, that are not beneficial. But I was very fortunate to see a very good HMO start from the beginning and see where it's gone and what it's done and how it was built up.
How much did it cost for you to go to medical school?
I really don't know at this time. I lived at home when I was in medical school, and it was not very costly. I just don't know what the cost was. I would doubt. I'll have to ask my mother, who's still alive, but it was not very costly.
How do you how do you think the cost for you to go to medical school compares with the cost today in terms of influencing young doctors' decisions after they graduate?
Yeah, no, I think more than that. I think it affects people who want to go into medicine.
Yeah.
At the time that we had, the cost of medical school was not that great when I went at all. It really wasn't a major consideration, other than I couldn't afford it. So, but I knew I wasn't going to go tens of thousands of dollars in debt as they do now. At that time, too, I think the earnings possibility were far greater than they are now. So that I think the thought, when you hear that the average medical student may finish with a debt of $100,000 or so, is frightening. I think it's frightening. I think it's terrible. I think it's a definite disincentive to many people to go to medical school.
How have doctors' salaries changed over the course of your practice?
Oh, I think that's hard to answer completely. I think most doctors are working harder and making less. I think their costs have gone up dramatically. But, don't misunderstand me. Doctors make a good living. I'm not claiming poverty by any means. Doctors make a good living. And, one of the nice things about medicine is that if you want to be solo, you can be solo. You want to be part of an HMO. You want to be at the university. There's a vast variety of ways that you can practice and you can do things.
How has malpractice insurance changed over the years?
It's gotten much higher than it was, and it's to the point in radiology it's still semi-reasonable, but in some of the specialties it's just going to force people out of practice. And what they should do, which they won't do because of the politicians, they should do what California did. They should put a cap of $250,000 on pain and suffering. And that would do a long way to reducing the malpractice premiums. Our problem in radiology are many, but for example, mammography, we know that 10 to 15% of cancers of the lung cannot be seen on the X-ray. Even in retrospect, when you go back with a magnifying glass, you can't see the cancer. Well, now the women who get cancer of the lung, many of them, through the trial attorneys, are bringing suits against the radiologist. And after all, here's a woman in court who's dying of cancer, and the radiologist missed it on a mammogram. Didn't miss it, it didn't show, and it's terrible. It's terrible. It's a terrible problem. Terrible problem.
What were the typical fees for an office visit when you began practicing?
Oh, I don't really remember what they were. I'm sorry, I can't answer that. They're higher now, but we didn't have $1 million pieces of equipment. We didn't have $1 million pieces of equipment.
I guess you've already talked about how you learned the business of medicine, but do you have anything further to say about That,
Well, I think that in medical school we certainly need more training in the business principles of medicine. I think most doctors finish and they know nothing about accounting and nothing about cost structure, and I think that that really should be an important part of the curriculum. Within limits, but they certainly should have some of that. They know nothing about statistics. I think our teaching of medical ethics is horrible in school. I think teaching our doctors how to communicate, I think is really needed. I think personal relations is needed. I think there are a lot of non-scientific, and these are non-medical talents or traits or properties which really are not handled well in medical school.
what are some changes that you've seen in the demographics of Worcester?
I don't know. I really haven't seen any. I haven't. I just know, you know, we're in a position where our patients are referred by referring physicians. So I think they've probably seen a lot more of what goes on than we do. We've never paid attention to demographics.
Has the ethnic background of your patients changed at all?
No, I don't think so. We never paid it. I'm not sure I can answer that.
Okay.
I can't answer that. I have no idea race, religion, the color, or anything of any of our people. Patients are patients. I wouldn't know. I would have no idea. I have no idea whether they can pay or not. I have no idea whether our patients pay or not. We write off thousands, tens of thousands of dollars from people who can't pay. I mean, we never paid it. We never asked a single patient, can you pay for this procedure? That just doesn't figure into the way we did business at all.
How has women's health in Worcester changed over the course of your practice?
Well, I think mammography has really come into its own. You know, many years ago, patients did not do mammography. We still don't do enough mammograms. Certainly ultrasound looking at the female pelvis wasn't here at all. Certainly ultrasound in terms of obstetrics was not here at all. So these have been very major. Certainly bone density studies were not here at all. So these are all very major changes in terms of women's health. We've always tried to be, you know, at the forefront of that, and I think we have.
Have there been changes in how children are cared for at all?
Not that I know of. There may be. You have to ask the pediatricians.
Yeah.
Not that. We don't see a lot of pediatrics because very little pediatrics has to be hospitalized. It's really an outpatient service.
Have you ever practiced anywhere else besides Worcester?
Well, in Boston, at the Massachusetts General Hospital where I trained. I was there for 7 years, as I said before. But no, primarily no.
Okay. Are there any major differences between practicing in Worcester and Boston?
Oh, I don't know. I think it depends more on your setting where you're at. If you're at a major university hospital, such as Mass General, it's a little different. But St. V's was as close to a university hospital as you could possibly be.
What were public perceptions of doctors like when you started practicing?
Oh, I think that the perception of doctors has gone down. I really do. And I think that at one time the doctor was God. I don't think he's God anymore. And that's too bad. I think doctors get a lot of knocking around for things that they should not be knocked about. And most of the doctors, almost all the ones I know, are very good people. Are very good people.
How do you feel the role of the physician in the Worcester community has changed?
I can't answer that. I don't know if it's changed at all, and I can't answer that question.
Are there Worcester physicians that you admired when you started practicing?
I really knew, I really was a total stranger to Worcester. I really didn't know anybody here. When I came, I found some very fine physicians on the staff at St. Vincent. I really did not meet a lot of the other physicians around. I don't know. I'd come from the Massachusetts General Hospital. I had some of the greatest physicians in the world who were my friends. I found many fine physicians in Worcester when I came, as I still are. There's some great doctors here.
Do you find yourself admiring young physicians now that you're older instead of, obviously, older physicians when...
Yeah, well, there are a lot of good young physicians too, sure.
Yes.
Sure.
Could you briefly comment on the experience of the female physician in Worcester in the 50s and 60s?
Yeah,
Since then?
yeah. Well, I think when I was graduating from medical school in 1958, we had 4 out of 75 members of our class who were female. I think now, close to 50% of the classes are female. We've always had female residents here. One of my staff members has been female for 15 or 20 years. And as I said, gender, race, sex, ethnic, no, religion had no meaning, has no meaning. Good doctor is a good doctor.
What do you like best about practicing here in Worcester?
Well, I liked, I guess in a humanitarian way, I like being able to help very sick people. I think that was my favorite thing here. In a nice setting with nice people to work with, not only in my department, but in the whole community.
And
Teaching the students, I love teaching the students, love teaching the residents. We love doing that.
And what do you like the least about practicing here?
I don't think there's anything in particular that would be different practicing here than elsewhere. All right, I really don't. I think that all of the inhibitions, all of the regulations might be worse in the state. I don't think there's any. I think Worcester's a good place to be.
And lastly, do you have any advice for younger doctors just starting out?
Well, what I would do, sure, I think they should really be committed to taking care of sick people. They should be aware of what's going to cost them financially, and they hopefully can make so that they don't finish being so in debt that the rest of their lives are in trouble, and that they should get ready to work hard and have a very rewarding life. Have a very rewarding life.
Well, that brings us to the end of our interview.
Well, thank you very much for seeing me.